Hello, I'm Dr. Barry Tedder from St. Bernard's Heart and Vascular in Jonesboro, Arkansas. I'm an interventional cardiologist for the last 30 years there and have been working with the Avinger Pantheris device since its inception. This is a case that we're going to discuss that really shows the utility of the 6 French below the knee device, where we have complex disease. So the case study is a 47-year-old white male with diabetes who presents with a ulceration on the dorsal or anterior surface of his foot. It's been cellulitic, purulent, and thought to be a spider bite initially. He was treated with IV antibiotics. Interestingly, he had excellent pulses, including a very good posterior tibial pulse. His segmental Dopplers had revealed a TBI of 0.57 and a non-compressible vessel for the ABI. This kind of illustrates sometimes you got to, if you find a pulse in the foot, it may not be enough because of the lack of flow to the anterior surface. So what we see, and I decided it was important to do an angiogram on him with the ulceration, and I think that's important in anybody with a diabetic ulcer below the ankle. So what we saw is that he ends up having normal above the knee vessels. And at the bifurcation, the angiogram showed a very tight osteal anterior tibial artery, as well as TP trunk stenosis at the bifurcation. The AT, as you can see in these images, the proximal posterior tibial had severe disease as well, and the perineal was relatively normal. There was also a subtotal occlusion in the anterior tibial and the mid-distal segment. So what we started with was getting wire access. I elected to do a little bit of predilatation, particularly of the mid to distal AT, because it was totally occluded, to make sure the nose cone would get through adequately. Probably didn't have to do that, but I chose to. And then we used the 6 French device with significant debulking, starting at the ostium and taking care of that lesion, and then going down and taking care of the mid-distal subtotal occlusion with the Pantheris, with good cutting of plaque, staying within the avoiding deep structures. So the nice, interesting thing about this case is using the sizing, where you can use OCT to size the vessels below the knee, and therefore we can more accurately get the sizes. You can see on the images, again, you can see the slow flow down the anterior tibial with subtotal occlusion in the distal vessel. As we get into the imaging, we want to see the deep structures. You can see initially that we're not where the plaque is and where the media is, and we want to avoid cutting in deeply into the media. As we said, we'll rotate. One of the key things to remind yourself about rotating is to rotate back both directions to prevent wire wrap. We can see relatively normal structures here. And then we see in plaque there, we cut a little bit of plaque down to where the appropriate deep structures. We can see there's just minimal plaque there, but there's some of the plaque with a little bit of deep calcium, but not too hard to cut. And fairly soft plaque right here at 12 o'clock, which we're starting to cut and get down to the media and stop, just leaving a minimal amount of plaque behind. The nice thing about the below the knee device is the vessels are small and imaging is quite good. So I ended up doing, as you can see on the angiogram, with a 4mm drug-eluting balloon, I was able to get excellent anterior tibial results, and also with a 3.5mm balloon in the distal AT after atherectomy, excellent results. So then I did address the TP trunk with atherectomy with the 6 French device across the TP trunk and some of the proximal PT plaque, and dilated it up with a 3mm balloon. 3.5mm balloon proximally. Some of the distal vessel in the PT was done with angioplasty alone, but as you can see on the final angiogram, we got excellent results of the AT with no dissections, PT being a much smaller vessel and is widely patent. And what is really useful in these bifurcation lesions is we can cut and debulk And we really have very minimal plaque shift or any problem with plaque shift when we're cutting these bifurcation lesions. So I think one of the big utilities in the below the knee device is bifurcation lesions, where we can avoid any kind of bifurcating stents and really avoid a lot of the dissections. Knowing by imaging the size of the vessel, more people are moving toward using IVUS size below the knee vessels because we tend to undersize. You can utilize OCT with the Pantheris in the same way and get a fairly good sizing, which we tend to underestimate the size, and OCT is a little more accurate at getting the appropriate size to use the appropriate balloon. And I'm finding getting much better results in the overall lumen size by using OCT guidance to figure out the true vessel size. Again, plaque debulking, noticing where the calcium is, often deep calcium and not superficial calcium, so that the cutting is adequate without having too much trouble. There are cases where the calcium is superficial and will not cut as well. But again, this is an excellent illustration of not relying on just having the pedal pulse, but knowing where the wounds are and really addressing, doing an angiogram, and then two, significant debulking of bifurcation lesions as well as total occlusions, where we get very good luminal size and luminal quality just after atherectomy alone. There's often cases below the knee where I'll just do atherectomy alone with no balloon because the results are adequate.